Now, so we talked about high, mid, and distal. So how to identify the rectosigmoid junction? There are two different school of thought. Somebody accept the bony landmark, either S2 or S2, S3 junction. This is the rectosigmoid landmark. Some people say no, from where the rectum and sigmoid leaves the sacral base, go away from the sacral base. This is the rectosigmoid. So this is the area where we can consider as rectosigmoid, but this is not a very fixed point as far as the MRI or endoscopy, colonoscopy, or rectal cancer is concerned. So high, mid, and low we have covered. Here I would like to mention this is the anterior peritoneal reflection. I will show it on MR again. It is very important for mid and high rectal tumor. Why anterior peritoneal reflection identification is important. So we need to differentiate low rectal cancer from high rectal cancer. One idea is distalmost 5 centimeter is the low rectal tumor. Some people classify in this way. On coronal section, once you identify the levator plate insertion, this is the levator plate insertion here. You draw an horizontal line here and the anal verge here. So this length of the rectum is considered as the low rectum. Why this is especially important? Because you need to identify the distance between the topmost end of the anal sphincter and lowermost extent of the tumor. There should be at least 2 centimeter free margin to consider is as resectable for sphincter sparing surgery. Now look at this picture. So this is the anal verge. Here is a mucosal thickening or rectal tumor. Now this is the upper end. This thickening and black thickening is the external anal sphincter. So this is the sphincter length. Here is the lowermost extent of the tumor. So you need to measure this length to identify whether there is, resection margin is possible for LAR and TME is possible or not. This is important, and this can be measured by DRE, digital rectal examination, by MR measurement, as well as from the colonoscopy, length of the anal verge up to the lower extent of the tumor. So we'll go back to the axial anatomy. It is more important for you radiation oncologists. So let us come back to the 3 layers of the rectal wall. This is an histology slide. So there is mucosa, there is submucosa, there is muscularis propria, and outside this muscularis propria, there is fat, we call mesorectal fat. Outside this mesorectal fat, there is mesorectal fascia. What is MRF? It is an inner layer of the endopelvic fossa. It splits into 2 layers. One is the visceral layer, and the other is the parietal layer, which goes to the lateral pelvic wall. This MRF is extremely important because today's rectal cancer surgery is total mesorectal excision, and you need to identify the MRF, whether there is disease infiltration outside the MRF or not, whether it is threatened, whether it is touched, or whether there is infiltration and infiltration beyond the MRF. It is very important to identify. Now, this MRF, if you could realize this thin structure here, it is the MRF. Whenever we'll talk about surgical resectability, the same MRF, we will term it as CRM or circumferential resection margin. So look at this MR picture. This is axial T2, small field of view. So bladder, prostate, rectum. This hyperintense is the intraluminal fluid. Now this is the rectal mucosa, relatively black. Outside the black, relatively hyper is the submucosa, and there is a smooth black thick wall. It is the lamina propria or muscularis propria. So any tumor which involves only the mucosa and submucosa is T1 tumor. If it infiltrates the muscularis propria, it is T2 tumor. Once it infiltrates beyond the muscularis propria and enter into this space, mesorectal fat, it is T3 tumor. Now this T3, there are several subclassifications. Before I enter into the T3 subclassification, let us just take few examples. So this is a axial T2. Here is a thickening, which is a rectal growth, and it is confined within the muscularis propria. So this is a T2 tumor. Whereas here there is a thick bulky tumor, and if you look at this 12 o'clock position, there is tiny tumor deposit outside the muscularis propria into the mesorectal fat, but mesorectal fascia is quite away from the tumor deposit. So this is a T3 tumor. Here the MRF is not involved or not threatened. And if you look carefully within the mesorectal fat, you will find tiny normal looking lymph nodes here and mesorectal venous vessels or veins. These are important. Why? I'll discuss later on. So this is a T3 tumor. Now T3 I'll elaborate later on in my next slides. Let us just come back to MRF again. So MRF is a structure which is widely separated in mid rectum, but it is like spindle separated. Upper rectum, it is more closer to the rectal muscularis propria. Again, in the lower rectum, it is again closer to the muscularis propria. So upper rectal tumor and lower rectal tumor, the distance between the muscularis propria and MRF is less, whereas in the middle rectum, the distance is more. So for upper rectal tumor and lower rectal tumor, chance of MRF get threatened or invaded is slightly more than middle rectal tumor. I'll just highlight the anterior peritoneal reflection. It is very important. Proximal rectum is the anterior surface of the proximal rectum is covered by the peritoneum. Why this is important? This is sagittal image. If you look at this area, there is a peritoneal reflection here. This is seminal vesicles, bladder, prostate. Here is the anterior peritoneal reflection. Once the proximal or mid-rectal tumor touches the anterior peritoneum, it is equivalent to parietal peritoneal involvement. It is not a T3 tumor. It should be considered as T4A tumor. What is T4A? Once the tumor goes beyond the MRF or CRM, it is T4. If it invades any pelvic organs, T4B, no pelvic organ invasion, only infiltration beyond MRF, or it touches the parietal peritoneum, it is T4A. Look at this MR image. Can I interact with the resident? Can you hear me? Hello?
Yes, sir, you are audible.
Sir, the residents can hear you, but they are not given the rights to talk. Because,
Okay.
Yes, sir.
Okay, let's move on. So this is a bulky tumor between 12 to 3 o'clock position. This is the muscularis propria. And there is clear infiltration of the tumor beyond the muscularis propria within the mesorectal fat. This is the mesorectal fat. This is the outer margin of the mesorectal fascia. And tumor directly had invaded the mesorectal fascia and it is bulging beyond the mesorectal fascia. So this must be a T3, maybe T4A, and there are multiple tumor deposits within the mesorectal fascia. Maybe this is a node. This is lateral pelvic wall musculature, lateral pelvic wall vessels, iliac vessels. Here is a node. These are the vessels. Here is a node which is outside the MRF, has to be identified separately. So this is outside MRF and this is an extra mesorectal node. This has to be addressed and should be mentioned on our MR interpretation. Little more anatomy. So MRF here, MRF, seminal vesicles, MRF. Posteriorly, the MRF and presacral fascia are important to identify because this is surgical. If surgeon dissects beyond the MRF posteriorly and he invades into the presacral fascia, there will be significant amount of bleeding because the vessels and lymphatics, this area is rich. And if tumor invades beyond MRF posteriorly to invade the presacral fascia, it is again T4 tumor. So let us talk about the levator plate. We need to look at levator plate on coronal section. This is a levator plate like the diaphragm, and this fat is ischioanal fossa or ischiorectal fossa. Low rectal tumor may invade directly into the ischiorectal fossa, may go up to the lateral pelvic wall. It may invade the levator plate. The staging will be different. So there are various sequences and projection like sag T2, like axial T2, like coronal T2, and diffusion. These are the four main sequences of MR we need to look at. So each and every projection like sagittal, axial, coronal, and diffusion, they have importance. So primarily tumor localization, the length of the tumor, the distance from the lower extent of the tumor up to the anal valve or up to the sphincter should be looked at on SAGT2. So tumor localization, distance from the anal valve or sphincter to the lower extent of the tumor, the relationship with the peritoneal reflection, those are the things we need to look at. Sagittal T2. Axial T2, especially small field of view, thin section, very important. This is the main sequence where we should look into the tumor and its axial spread is the small field of view, axial T2, thin section, no gap between slices. These are important. So the CRM, MRF, nodes, extramural venous invasion, those are the things we need to look at this sequence. Coronal sequence is important to measure the distance between the sphincter to the lower extent of the tumor, and extramural venous invasion should be looked at coronal sequence. I'll show you pictures, not to worry. And diffusion is very important, especially for the mucinous tumor or signet ring tumor, their diffusion restriction. So interesting is the nodes of mucinous tumor or aggressive active tumor will also show diffusion restriction. So if you look at diffusion, the localization of nodes outside the mesorectal fascia will be able to pick up on diffusion, and then you come back to the T2 and identify those nodes, especially the extra mesorectal nodes, which are very important to identify, especially for the radiation oncologists, because you need to address those nodes within your radiation field to treat those nodes. Another important area for diffusion restriction is post-radiation assessment, is because post-radiation there is tumor fibrosis. So you're looking at only T2 sequence, it is very difficult whether that thickening is active tumor or it is post-radiation fibrosis. So diffusion will help you. The area of diffusion restriction, I'll show you pictures, will tell you that these are the area of active tumor, and that's the way you can assess that treatment response or radiation response or chemoradiation response, and you can grade the tumor regression grading or response evaluation. I'll show you pictures. So how do we scan? This is the longitudinal axis of the rectum, and this is the tumor. You have to scan perpendicular to the longitudinal axis, the scan planning. Similarly, for lower rectum, your scan planning is slightly different. For the upper rectum, your scan planning is slightly different. Now, what are the main area we need to look at? The concept of TANCE, T-A-N-C-E. So tumor, anal sphincter, nodal status, again within the mesorectal nodes and extramesorectal nodes, the CRM status and extramural venous invasion. These are the 5 important things we need to comment on MRI. Okay, I'd like to little elaborate the T3 stage because T3 has immense importance. So let us talk about T staging again. So T1 tumor, mucosa, submucosa. T2, once it touches the muscular dysprophia. T3, once it goes beyond the muscular dysprophia. T4 we know, T4A, T4B. Now T3, I would like to elaborate. If the tumor infiltration is very close to this place, whether the tumor is very close to this MRF, so this will subclassify the T3 stage. If it goes just 5 millimeter beyond the muscular dysprophia, it is T3A. Now, if it goes up to 10 millimeter, it is T3B, 15 millimeter T3C, and more than 15 millimeter, it is T3D. So T3D is more closer to the MRF or CRM, and T3A is more closer to the muscular dysprophia. Take one example. This is an anterior rectal tumor. This is the rectal lumen. Posteriorly, you could easily find out the muscular dysprophia. Anteriorly, there is a bulky tumor here, muscular dysprophia, and MRF here, MRF. So here, there is infiltration of the tumor beyond the muscular dysprophia, which has gone very close to the MRF. So you can call it, this is definitely T3, maybe T3B, or somebody might call it MRF is almost threatened. So these are the category of tumor where you cannot do upfront surgery or upfront TME. So you have to do something in terms of neoadjuvant treatment before surgery. Let's take, okay. So what is extramural venous invasion? So if you look carefully, this area, so this is a tumor. Here is the MRF fat. This is a vein. So extramural venous invasion. Once there is tumor infiltration within the vein, those normal looking vein will be dilated, will be tortuous. So histologists comment on it as lymphovascular invasion. We radiation oncologists can comment as extramural. This is a vein which gets dilated, and why this is dilated? This is the normal appearance of the vein. Why this is dilated? Because of the venous tumor invasion. So this is called extramural EMVI, venous invasion. This is a high risk group tumor. You might get EMVI within the mesorectal fascia. You might get EMVI outside the mesorectal fascia. So the importance is similar. You might get tumor deposit within the MRF. You might get tumor deposit outside the MRF. So here is a bulky tumor here. So anterior between 2 o'clock to 6 o'clock, there is extramural invasion invaded up to the mesorectal fascia. There is node outside the mesorectal fascia and extramural venous invasion outside the fascia. Somebody might ask, so this is a tumor deposit. Somebody might ask, how will you identify which was a tumor deposit and which one is a lymph node? So just apply your common sense. Anything which is irregular in outline is a tumor deposit. Anything which is smooth in outline is a node. Very simple. Let's take 3 different examples here. So loco-regional staging to identify the treatment options. So there is a tumor here, This is the lumen. This is the muscularis propria. This is mainly a mucosal and submucosal tumor. Muscularis propria is intact. There is no infiltration beyond the muscularis propria. The mesorectal fat is crystal clear. So this is a T2 tumor. If it is node negative disease, upfront TME or upfront surgery should be the treatment option. If you look at this little bulky tumor, and on this side, on the left side, between 12 to 6 o'clock position, this MRF, this fat is infiltrated by the tumor. There's a node here, but there is no infiltration behind the MRF. So this is a T3 tumor. You can subclassify and you can discuss in the MDT. If it is a node positive disease, you know better than me, the patient will need neoadjuvant. And this is a locally invasive tumor, very bulky mass. MRF has been infiltrated. There is node outside the MRF. Extramural venous invasion is there. Tumor deposit here. Tumor deposit, nodal deposit there. So this is locally invasive beyond T3, T4A tumor. So these are the things we need to identify before we plan for neoadjuvant treatment or radiation planning. So let me talk about nodal staging. We all know in 1 and in 2, if the number of nodes are within 3 regional node I'm talking about, it is in one lymph node in 1A, 2 and nodes 2 and 3, I mean more than 2 or up to 3 in 1B. If it is more than 3, like 4 to 6, it is N2A. If it is more than 6, it is N2B. This is about regional lymph node. Now, nodal station nodes can be classified into 2 categories: regional lymph nodes, whether it is within the MRF or mesorectal lymph nodes, or it is outside mesorectum. So, outside mesorectum nodes are again obturator node, lateral pelvic node, or iliac node. Yes, lateral pelvic node or iliac node. Now, from mesorectal nodes can go superiorly up to the superior rectal nodes, again can go up to the inferior mesenteric nodes. Those are the 2 areas we need to identify. Especially superior rectal node, if it is associated with high rectal tumor, your field will automatically cover. But if it is a low rectal tumor and there is a superior rectal node, that is very important, because in your planning that should be covered. And if there is an inferior mesenteric node, that also need to be addressed, because that has to be covered in your treatment field. Now, mesorectal node will go into the superior rectal node or inferior rectal node, whereas extramesorectal node like obturator or especially the lateral pelvic wall node, if they go further beyond, further cranially, they usually will go to the retroperitoneum. This is the simple lymphatics. So mesorectal nodes, if it goes more cranially, it will go to the superior rectum and inferior mesenteric group. and lateral pelvic wall node or extramesorectal node will go to the retroperitoneum. That's the
Sir, this is
fundamental.
Anupam here, sir. Sir, I would be very sorry to interrupt you. Sir, can you please finish it in the next 2-3 minutes because we need to discuss also, sir.
Yes, please continue.
You can take 2-3 more minutes and then we will start some discussion.
Okay.
On this.
Okay. So just take few examples. This is another case. There is a bulky tumor here. I'll finish within 3 minutes. Huh? Yeah. 1 minute for this slide and 2 minutes for tumor regression.
Okay, sir.
So there's a bulky tumor here. Multiple nodes. This could be a deposit, well-defined node within the MRF, and there's a node outside MRF. Similarly, just few examples. There's a bulky tumor here. MRF. Tumor deposits here within the MRF, and there is a tumor deposit invading the MRF and outside the MRF. Similarly, here, take this picture. This is MRF, this is MRF, this is MRF. Rectal tumor here, multiple deposits, either nodal or tumor deposit, and multiple deposits. This is lateral pelvic wall. There is a lateral pelvic wall node, multiple nodal deposit outside the MRF. So this is a locally advanced tumor. Let us just talk about tumor regression. How do we assess tumor regression? Here the diffusion sequence is very important because always T2 will not be able to tell you whether it is an active tumor or not. Now this tumor regression can be no regression, can be minimal regression, can be moderate regression, might be good response, might be complete or total response. So that has categorized. So TRG 1, 2, 3, 4, 5. If you look at this picture, there was a tumor here. MRF is completely intact, minor infiltration beyond the muscularis propria, and post-neoadjuvant, post-radiation, there is a diffusion restricted area, but rest of the area, this is the MRF, this is the MRF, this is the mesorectal fat, this is the mesorectal fat. So there is a small area of diffusion restriction. So this bulky tumor has been converted into a small active tumor. So this is to be considered as mixed response, but good response. So I'll call it more than 75% response. It will be in the TRG2 category, good response, dense fibrosis, more than 75%, minimal residual tumor. But if you look at this image, the pre-treatment, there's this much of tumor, and post-treatment diffusion and ADC. ADC is just reverse, diffusion restriction, bright, ADC, black. So you see there's minimal reduction, minimal bulk reduction, but most of the tumor is still present. So it is either in the category of TRG4, if somebody want to call it TRG5, okay. If somebody want to call it TRG4, okay. So there is minimal response, response is not satisfactory. Here, there was a less bulky tumor pre-treatment and node positive disease. Post-treatment, only minimal diffusion restriction and minimal hypointense or black signal on ADC. So this is a good response. So it will be in the TRG4 category. This is a TRG2 category. Very good response. So this is the way we identify tumor regression response. Some people take help of the contrast study, but we follow the European school. We look at it mostly on diffusion. I would like to finish my talk. Oh, there is no scope of interaction now.
Okay.
So
thank you so much.
The last image is bulky tumor of the proximal rectum. You could see that MRF is anteriorly invaded. It is actually the anterior peritoneal reflection. If you look carefully, not just MRF, this is a female patient. There is ovary on the right side. It is the fundus of the uterus. If you look carefully, the bulky tumor has gone beyond the. There is loss of fat plane with the uterine fundus. It is actually invaded the uterine fundus. So this is an example of T4B tumor. And if you look carefully here, the vessel within the MRF is dilated and tortuous. So this is EMPI, extramural venous invasion. So this is T4B tumor. This is the way we interpret MR images. So back to the.
Thank you so much, sir. Thank you so much, sir. Hambi, are you there?
Yes, I am here.
So do we have any questions?
Not yet asked till now. If you have to ask any question, they can write in the chat box. but till now no question yet asked.
Yeah,
Sir,
I
if
think
you want to continue the
Dr.
discussion.
Dr. Zia has asked a question. Like EMVI is seen by venous dilatation, is what he understood. I mean, yeah, it is the venous dilatation due to the venous infiltration by the tumor, Dr. Zia. So that is what Sir has told, and he has also mentioned that whenever there is a surgical specimen seen by interpreted by a pathologist, it is often infiltrated, interpreted as lymphovascular stromal invasion (LVSI). So this is what precisely we were here. Partha sir, like sometimes the residents, when we were residents, and the very common problem that residents often have is like, identifying the mesorectum, which you have very, very nicely highlighted over here. The CRM, the concept of CRM, the substages of T3 is all have been very well taken care of. And thanks to you that you have also included the tumor regression scores. Now, this is something that we need to learn these days, because simply giving in an NSCT and NSCT RT and then handing over the patient to the surgeon without seeing the response score, MR response score of the tumor is is now a talk of yesterday. These days we also need to see how good this response scores are, because there are literatures where they say that the better the response score, the higher is the prognosis of the tumor. So this is what precisely Dr. Shamui has catered to us. Thank you so much, Partha sir. And I would request you, if you want, we would like to have you till 9:30. You can, have a good break. Maybe later on, if students have any questions, then we can discuss at 9:30 after Dr. Kannan's talk. Thank you so very much, Partha sir.
Thank you, sir.
Thank you.
Yeah.
Thank you. After the first talk is over, sir, Dr. Pal, should we start the second session? Hello.
Yes, we can. I think we can start the second talk.
Okay.
Sir, Pal sir is already said.
Okay. Our next speaker is Dr. P. Kannan, respected consultant, respected assistant professor from PGI Chandigarh. And our next topic of discussion is conventional radiotherapy planning in anorectal malignancy. Sir, please start your session.
Yes. Shall I share my screen?
Yes, sir, please.
Is the screen visible?
Yes, sir, it's visible.
Okay. Okay. So first of all, I would like to thank AROI West Bengal chapter for giving me this opportunity to deliver this lecture on 2D and 3D planning in anorectal malignancies. So since the target audience is mainly junior residents, I have kept it very simple. So I hope the attendees shall be able to understand at the end of this lecture the basic anatomy, the lymphatic drainage, and what are the indications for radiotherapy, and what are the pre-radiotherapy requisites required before planning, and then the external beam radiotherapy technique in detail we'll be seeing. First, I'll be discussing the 2D planning of rectum, followed by the target volume delineation for rectum. Then we will go into anal canal. So first, let's start with rectum. So the anatomy has been covered by the previous speaker very well. So I will just cover the basic aspects alone. So the rectum, it starts from the anorectal ring, which is situated approximately 4 centimeter from the anal verge. So, and it is divided into 3 parts: upper, mid, and then lower. The lower rectum is approximately 4 to 8 centimeter from the anal verge, and mid third is around 8 to 12 centimeter, and upper third rectum is approximately 12 to 15 centimeter from the anal verge. And this is the sphincter complex region. It is made up of internal sphincter as well as the external sphincter. The internal sphincter, it's nothing but the circular smooth muscle fibers of the rectal wall, which continues down as the internal sphincter. And external to it, we have the external sphincter, which is formed by the fibers from the levator ani and then the puborectalis, which is responsible for the maintenance of continence. Coming on to the spread, how do these rectal cancers spread, which is very important for the target volumes. Locally, it can spread in 3 ways, either by local or by lymph node or through hematogenous route. So locally, it can invade into the adjacent organs. So what are the adjacent organs? We have bladder, prostate in males, and the uterus, and then the vagina in females. And we sometimes will have even adjacent bowel loops being infiltrated by the rectal cancers. And the second mode of spread is through the lymphatic drainage. So the predominant route of spread is through the mesorectal nodes, then followed by nodes at the bifurcation of the inferior mesenteric artery, which originates from the aorta and divides into the sigmoid and superior rectal artery. Then we have the internal iliac nodes and then the presacral nodes. These are usually the first station nodes. And we can have external iliac lymph node involvement if the tumor it invades the adjacent structures. And third mode of spread is through hematogenous route, which is most commonly found in liver, followed by lungs and then bone. So coming on to the radiotherapy planning process. So broadly, we have three major steps in the process of radiotherapy. One is pre-planning, which includes the clinical evaluation of the patient and followed by TNM staging and deciding the treatment intent of the patient, whether it's radical or palliative, and deciding the treatment modalities for that instant, either surgery, chemotherapy, or radiotherapy, or a combination of these modalities. So once we have decided that, then we go into the radiotherapy planning proper, which includes explanation to the patient about the radiotherapy and then the side effects and getting their consent, followed by immobilization and then the data acquisition, target volume delineation, and then the planning based upon the technique, and then plan evaluation followed by treatment delivery, and followed by weekly review during the radiotherapy and recording and reporting the treatment as well as the evaluation of outcomes in the follow-up. So briefly, I'll cover the treatment aspects of this rectal cancer. So any patient with rectal cancer, you do the evaluation and classify into metastatic or non-metastatic. So non-metastatic cases, then MRI is no more an optional tool. It's a mandatory tool because it gives so much of prognostic information and it helps in deciding many things based upon the features which is found in MRI. So based upon that, we can classify the patients into three groups. One is low risk, and the other is moderate risk, and third is high risk. Low risk patients generally go for upfront surgery. Moderate risk patients, they generally require some form of neoadjuvant treatment, either in the form of short course or a long course chemoradiotherapy, then followed by surgery. And high risk patients, obviously, they require long course chemoradiotherapy. And nowadays, total neoadjuvant is also being followed by surgery. So the MRI aspect has been nicely covered by Sir in the previous talk. So I wouldn't go into much details, but it gives very much information which is required for radiotherapy planning as well as for surgical planning. So it gives about the location of the tumor and then the extension of the tumor, the nodal stage, and then the MRF status and EMVI, and as well as the involvement of levators. And based upon the MRI, we classify this T3 into A, B, C, and D based upon the extension beyond the muscularis propria. And this CRM status is very, very important because it's an independent predictor of overall survival. And we call it as involved when the MRF is breached, or when it is less than 1 mm, we call it as threatened. So when we need a MRI report which tells you about all this information, so always request your radiologist for all this information before choosing a patient for radiotherapy planning. So these are the risk groups we had earlier based upon the MRI. So the low risk group are the patients with T1, T2, and T3A tumor, which is just it's extending beyond the muscularis propria, just less than 1 mm, with no lymph node involvement. These are the patients who are at very low risk of recurrence and they do not require any form of neoadjuvant treatment and they can go straight away for surgery. And moderate risk patients are those who are T3B or greater, but still CRM is not threatened or not involved. You can have lymph nodes, but not threatening the CRM. And EMVI, we go for a neoadjuvant treatment, which is usually a short course. And high-risk patients are those with CRM threatened or involved, or if you have a tumors which is encroaching into the intersphincteric plane or involving the levator ani. So these are the patients who definitely require long course chemoradiation, or you can go for a short course also, but you need to delay the surgery for the downstaging purpose. So pre-radiotherapy requisites. So make sure before you plan a patient for radiotherapy, you have all this information available at your hand. That is full history, examination, including digital rectal examination findings, and the biopsy report, MRI pelvis, and CT thorax and abdomen. the colonoscopy report, and baseline blood, including the CEA. So the first step is always explaining about the procedure and getting consent from the patient after explaining in detail about the acute as well as the late toxicities of treatment. Next, coming on to the patient setup. So the first step in the patient setup is the positioning of the patient. So we have two positions, either supine or prone. Traditionally, prone position has been used, but we routinely follow supine position as it is more stable and comfortable, with hands either on the chest or above the head, and with immobilization for the popliteal fossa as well as for the feet by using the footrest. And use lasers for proper alignment of the patient in order to prevent rotation and then the lateralization. You can also go for a prone position with a belly board device. That is definitely helpful because it displaces the small ball anteriorly, thereby reducing the dose to the small ball, because it displaces the small ball away from the field of irradiation and thereby reducing the toxicity. So yes, there is definitely a dosimetric benefit, but it is less stable and you require a belly board. So this is these are the two CT images, one with belly board and another without belly board. You can see here that with belly board, the small bowel lobes are displaced anteriorly. You can see the abdomen which is falling into the belly board aperture. And in the field of irradiation, we hardly find small bowel lobes. But on the contrary, in patients without use of belly board, you can see that majority of bowel lobes are into the field of irradiation, so which may contribute to the small bowel toxicity. Next is the bladder protocol. So we need to simulate the patient either 2D or 3D with a comfortably full bladder protocol, because that helps in reducing the small bowel toxicity because it displaces the small bowel superiorly. So we routinely follow 500 ml over 45 minutes, which is the comfort bladder protocol followed in our institute. And next, about the rectum. Rectum, ideally, we want it to be as empty as possible, but at least the anteroposterior rectal diameter should be less than 4 centimeter. If it is less than 4, we proceed with the simulation scan. If it is more than 4 and it is not because of the tumor, then we need to give enema, or you give patients some sachets, Movicol sachets, and for a week, and then you repeat the simulation. Next is radio opaque marker. This is very, very important for a radiotherapy planning because it helps us in delineation and defining the volume very easily, especially when MRI is not available. So always keep the habit of keeping a radio opaque marker at the anal verge, one at the anal verge and one at the distal end of the growth if it is palpable through digital rectal examination. So this will serve as a reference point while defining the target volume. So in the 2D era, people also used to give barium for contrast. It's introduced into the rectum catheter, and as barium contrast is also used in the vagina for the identification and localization purpose. So in the CT simulation, we routinely use IV contrast because we'll be able to delineate the blood vessels clearly. That will help in contributing to the delineation of lymph nodes, and it will also help in identifying the gross tumor and then the nodes. And oral contrast can be used irrespective of whether 2D or 3D simulation, because you will be able to see the small bowel loops, and you can follow gastrographin 20 ml in 1 liter of water given at least an hour before the planning scan. Next, coming on to the data acquisition with CT, we acquire the CT scans from L2, L3 junction to inferiorly below 4 centimeter below the lesser trochanter with a slice thickness of approximately 3 mm. So now coming on to defining the target volumes. So how the target volumes are defined? For any site, the target volumes are defined based upon the patterns of recurrence which we have observed from the previous patients. So based upon that, the target volume for rectal cancer would include the primary tumor and then the lymph nodes at risk, which include the mesorectal nodes and the nodes in the presacral space, internal iliac nodes, obturator nodes, and external iliac nodes, definitely if there is adjacent organ invasion. So before going into the 2D planning, this is a small anatomical landmarks which you need to know prior to planning by simulator, 2D simulator. So this is the anterior view and then the posterior view of the pelvis. And this is the sacroiliac joint, and this is the sacral promontory. This is the iliac bone. This is the anterior superior iliac spine, the acetabulum, and this is the ischium, and this is the inferior pubic ramus, superior pubic ramus, and then the pubic symphysis. And posteriorly, you can see this is the L4 spinous process, and this is L5, and this is the iliac crest, and then we have the ischial spine, coccyx, and then the pubic ramus, and this is the obturator foramen. So, and this picture shows the lymph nodes of the pelvis in relation to the pelvic blood vessels and in relation to the bony landmarks. You can see the aorta, which divides into the common iliac artery at the level of L4, and then these common iliacs it divide into this external and then the internal iliac at almost near the inferior border of the sacroiliac joint, and these external iliac artery continues as the femoral artery below the inguinal ligament. And here you could see the para-aortic nodes, the common iliac nodes, and the external and internal iliac nodes, and these are the inguinofemoral nodes. And here you have the presacral nodes in front of the sacrum, and these are the mesorectal nodes. Coming on to the conventional planning, generally we do with a 3-field or a 4-field arrangement. So the portals for the anteroposterior or the posterior-anterior fields would be superiorly. Traditionally, it has been kept at L5S1. And inferiorly, we go 3 centimeters below the lower border of the tumor or the inferior border of the obturator foramen, whichever is more inferior. So in order to identify that, keeping markers will help us identify. This is the marker at the anal verge which we have kept in the patient, and this is the distal border of the goat. So you can go 2 to 3 centimeters below it, and it is well below the obturator foramen. So this should be our lower border. And laterally, we go 1 to 1.5 centimeter outside the bony pelvis, especially when there is adjacent organ invasion. We need to carve the external iliac node, so we need to go at least 1.5 centimeter. But nowadays, we have found that based upon the Dutch TMA study patients' recurrence patterns, they have found that they hardly find any recurrence above the level of S1, S2, or S2, S3. So especially in patients with no high-risk features like no nodal involvement and negative CRM, only one recurrence was found cranial to the S2, S3 junction. So these has allowed us to lower our upper border to S1, S2 at least, especially in these patients with no high-risk features. So which will contribute to reduction in GI toxicity because of small bowel dose. And this is again the simulation picture which shows, and here it shows the upper corner shields and then the lower corner shields. And coming on to the lateral field. Lateral field, again, the superior border remains the same as L5S1 and the inferior border remains the same as 3 centimeters below the growth. And the anterior border, it is either, this is the pubic symphysis, you can see it's kept either at the posterior border of pubic symphysis if it's a T3 case where you do not need to treat the entire external iliacs, or you can measure from here also from the sacral promontory, you can go 2 to 3 centimeter anterior, which will correspond to the posterior border of pubic symphysis. If we need to carve the external iliacs, the anterior, especially the anterior part of the external iliacs, we need to go up to the anterior border of this pubic symphysis. And posteriorly, we ensure that we go at least 1 centimeter behind the sacrum so that the entire presacral space is covered. Now coming on to the energy, we generally use 6 MV photon beams, and you can use anything from 6 to 15 MV depending upon the separation of the patient. So the simple beam arrangement would be a 3-beam arrangement where we go for a direct posterior and then you go for 2 lateral wedged beams to decrease the hotspot. And then the third, second type of beam arrangement, which we can go for a treatment of rectal cancer, is the direct posterior and then 2 posterior obliques. Here you can find 2 posterior obliques. Here they have used 2 laterals along with 1 direct posterior. So what are the differences between these 2 types of beam arrangements? So if you see the beam arrangement with the lateral field, the dose cutoff anteriorly will be very sharp. Whereas when you see with the 3-field plan, posterior obliques, you can see that there is a slight anterior spread of dose. So there may be anterior spread of dose, and then the small bowel toxicity may be slightly higher. Whereas here you can see there is a sharp cutoff here. And the another point which need to be remembered when we plan with the two posterior obliques is that the angle between the two posterior obliques, it should not be less than 45 degree, because as you decrease the angle between the two posterior oblique beams, there will be intersection, and then you will have a high dose in the gluteal and the natal cleft region. So which will increase the skin reaction and then thereby causing treatment interruptions. Next is a four-field beam arrangement. So this we do generally when there is a T4 disease where we need to carve entire pelvic lymph nodal groups, including the external iliac chain, so that the dose will be increased anteriorly. So with three fields, it is very difficult to get a dose anteriorly. So we need to supplement with an anterior field to increase the dose. So coming on to the dose fractionation, that depends upon whether you're going for a short course or a long course. If it is a short course, we go for a 25 gray in 5 fractions of 5 gray each, given over 1 week, followed after a week by a surgery. And if it is long course, we go for a 45 gray in 25 fractions over 5 weeks with concurrent chemotherapy. And whereas the dose prescription, it is to the ICRA reference point, which is usually the intersection of the beam, central axis of the beam. Now coming on to the 3D planning for rectal cancer. So the basic important principles which we need to remember is have all information available. That is, you should use the information from your digital rectal examination and then the colonoscopy, and as well as from the diagnostic imaging modalities, which are MRI and CT. If possible, always fuse the MRI with the planning CT. And please involve the radiologist if you are in uncertainty. That is very, very important. So now what are the target volumes? Let me keep it simple. First, you contour the primary, involved primary, and contour the involved nodes. And then you give a margin to account for the microscopic disease, which is the CTV primary, and then the CTV node. Then you go for a contouring of volumes which are thought to be at high risk of involvement, microscopic involvement, which is the elective volume. So let us see one by one. So first is the GTV primary, which includes the macroscopic primary tumor, that is the grossly visible tumor on your imaging, and including EMVI. If you find any extramural venous invasion, please include that in your GTV. But there is some controversy regarding whether to go for just contouring of macroscopic disease alone as GTV or including the entire lumen as GTV. There is no consensus on that, but you can always decide. It's always better to go with the lumen. I routinely do the entire lumen contouring, but some people do, if they are confident in identifying the GTV, then they contour the GTV alone, or if there is some uncertainty in the GTV, then you contour the entire lumen. Next is GTVN, which include all involved lymph nodes. Search for lymph nodes within the mesorectum and search for extra mesorectal lymph nodes and contour all the involved lymph nodes. Next, coming on to the CTV, as I said, CTV, it accounts for a microscopic disease. So from the primary tumor, we give a margin of 10 mm in all directions for the creation of the CTV. And for tumors which may be more mobile, especially the upper rectal tumors above the peritoneal reflection, where there can be more movement in the anterior direction. So you can give 15 mm anteriorly in such cases. Next, for the creation of CTVN, we give a 5 mm margin around the gross node, and then we create the CTVN. And make sure that after you create the CTV, you edit the CTV from bone or muscles if it goes into it. But don't edit it posteriorly when it is going towards the sacrum, just we leave it. And in case of obturator internus, we see if there are any obturator nodes are there or not. If it is there, we make sure that we go till up to the pelvic side wall by including the muscle. Next, coming on to the delineation of elective CTV. So what does elective CTV include? It includes mesorectum, obturator lymph nodes, presacral lymph nodes, and internal iliac and external iliac if it is a T4 disease. So let's see one by one how to do the delineation. Let's start with internal iliac. So the superior border of internal iliac is generally S1, S2 junction or 2 cm above the gross tumor volume. whichever is more superior. So I have told you the rationale for keeping at S1, S2 junction, because hardly recurrences are found above S2, S3 junction from where the rectum starts. So that gives us the rationale for keeping the upper border at
Sit,
S1,
Rio.
S2 junction.
Sit, Rio. Sit.
And suppose if you have a tumor there, then we need to go at least 2 centimeters above it. So whichever is more superior, then we have to go. So just see the uppermost extent of the gross tumor disease and decide your superior border for your target volume delineation. Next is the inferior border. So we contour the internal iliac vessels and then giving a 7 mm margin around it. And then we go inferiorly until you see the obturator internus muscle. So that forms the lower limit of this internal iliac nodes. Next, coming on to the lateral border, it said it's a 7 mm margin around the vessels, and then you edit it off from the normal structures, including the muscles like iliopsoas or the sacrum or the iliac bone, if it goes into it. And medial border, it's again 7 mm medial to the internal iliac vessels. So these are the vessels which are contoured. These are the internal iliac vessels. And this is the superior rectal vessel. And you can find, if you give a margin, it goes into the bone and it can go into the muscle. Then you make sure that you edit it off from the bone as well as from the muscle. And next is the anterior border. Again, it is 7 mm anterior to the vessels, and posterior it's the bone or the piriformis muscle at the lower level, and then the presacral nodal volume. So you'll have the internal iliac volumes on either side, and here you have the presacral volume. Moving on to the obturator nodes. So obturator nodes, it starts where you end the lower limit of the internal iliac. So where you see the obturator internus muscle. So this is the obturator internus muscle and this is the pelvic side wall. So you start the contouring of the obturator nodal level from these slides. And inferiorly, how long we go? So we go until we see this obturator artery exiting the pelvis. That is, you can see this is the obturator internus muscle on either side. And here you can see the obturator artery, which is just anterior to the muscle. And here you can see the obturator artery, which is just beyond the muscle. So it has exit the pelvis. So this is the lower limit of the obturator nodes. And the lateral limit will be the obturator internus muscle. But if you have some nodes, then better to go till the pelvic bony side wall. And then the medial border, we use a 15 mm or a 17 mm brush, and then we mark it. And suppose if there is bladder which is coming into it, please don't crop it from the bladder, because though you follow a comfortably full bladder protocol, the bladder filling is variable every day. So it's better to include areas of bladder if present. And anteriorly, we go till the anterior extent of the obturator internus muscle, and some people even go up to the anterior border of this pelvic side wall. And posteriorly, it is limited by the piriformis muscle. So this is the piriformis muscle, this is the obturator internus, and this is the pelvic side wall. Next, coming on to the third station lymph nodes, which are the presacral nodes. So presacral nodes, the superior border is again the same as your internal iliac. Where do you start? That is the S1, S2. You connect the internal iliacs on either side by the presacral volume. So that is S1, S2 junction, or 2 centimeters above the gross tumor, whichever is more inferior. So if you don't have this node, then it would be S1, S2. If you have a gross tumor here, then you go at 2 centimeters above it. And inferiorly, where we go either to the caudal border of mesorectum, or you can go till the tip of coccyx. So laterally, we ensure that we go till the sacroiliac joint. So this is the iliac bone, and this is the sacrum, which you can see, and this is the sacroiliac joint. So that forms the lateral border of this presacral volume. And anteriorly, it is 10 mm from the anterior aspect of the vertebrae and sacrum. So we use a 10 mm brush and then we contour it. And in the region of this superior rectal artery or the inferior mesenteric artery, make sure your volume is just 7 mm anterior to it. Whichever is more anterior, you can use that as the anterior border of this volume. And posteriorly, you can see this is the sacral sacrum, that is the bone. So it should be limited by the bone. And here you must see that if there is a sacral foramen or a sacral notch which you're seeing, please ensure to include it in the volume. So in this slice, we don't find a sacral notch, nerve root notch here, and here you can find that sacral nerve root notch. And please ensure that it is included, because that is one of the common sites of recurrence, this presacral site. So what is this superior rectal or the inferior mesenteric and then the sigmoid artery? We know that inferior mesenteric artery, it arises from the aorta, approximately at the level of L3 vertebra, approximately some few inches below the superior mesenteric. And this is the inferior mesenteric artery. If you follow it up from the aorta, you can see it can splitting into two, which is the superior rectal artery and then the sigmoid artery. And here we will ensure that our volume is at least 7 mm anterior to these vessels. Next, coming on to the delineation of mesorectum, which is very, very important. So superiorly, where does the mesorectum start? So if you are able to find this bifurcation of the inferior mesenteric artery into the superior rectal artery and the sigmoid artery, if you are able to find this, then that marks the upper border of the mesorectum. But in some cases, it would be really difficult to identify these vessels. So in such cases, what you do is you can go for this 2S3 junction as the upper border of the mesorectum, which fairly corresponds to that level of division of these inferior mesenteric artery. Inferiorly, how long do we go? So inferiorly, you go till the level of insertion of the levator ani into the external sphincter. Here you can see this is the levator ani, and here it forms this external sphincter, and this is the internal sphincter. So you see where this insertion, it is best seen in the coronal view. You can open a coronal CT or a coronal MRI, and you can see where the insertion of the levator ani is. And that is exactly where the mesorectal fat disappears. You will be seeing a mesorectal fat. This is the this is the rectum, and here you could find this is the mesorectal fat, and this is the mesorectal fascia. So you can find it as tapering from above. You can see if it is broad at the upper slices, and it will be tapering downwards. So where it tapers, and you almost see a mesorectal fat, and that marks the inferior border of the mesorectal boundary. So, but if you have a lower tumor which is going into the anal canal, so in such cases, your volume should go 2 centimeters below the GTV. For example, in this case, you can see that the volume is in the lower part. So here the mesorectum hence here, but you can't stop the delineation of the mesorectum at this level because you have a tumor sitting there. So you need to go a 2 centimeter margin below it, and then we mark the lower border of this mesorectum. Next, coming on to the lateral borders of the mesorectum. So if you see the lateral boundaries, it varies depending upon the levels, whether it is in the upper level or on the mid level or on the lower level. So always start contouring from the mid level where you can see the mesorectal fascia very easily, or it is clearly seen. So you start from this. For example, in this slice, you can see that this is the rectum and this is the mesorectal fat, and then you can see the mesorectal fascia here. Always start from that slice and then go either upwards or downwards and then finish the contouring. So in the mid slices, in the upper slices, it is the mesorectal fascia that forms the lateral boundary if it is visible. But if it is not visible, then it is the obturator internus muscle, or you can say the medial boundary of the internal iliac nodal station, or the medial boundary of the obturator volume. So in the lower slices, if you see, the lateral edge will form this levator ani muscle. So you can see the rectum and then the levator ani muscle, and that forms. Make sure you include it. You don't just contour the rectum and leave it. We have to go till the external boundary of this levator ani muscle. Next, coming on to the anterior border. So anterior border in the upper slices, as I said, you go, the upper border is at the bifurcation level. So, and you go 7 mm anterior to it. And this is important. In the mid and then the lower slices, we have to go at least 1 centimeter anterior to the mesorectal fascia. So if you see, this is the rectum, and here you can see the seminal vesicles. And we have to go, whatever organ is there anteriorly, we have to go 1 centimeter into it from the anterior, 1 centimeter anterior from the anterior border of the mesorectal fascia. Then posteriorly, we include the anterior surface of the sacrum. That forms the posterior boundary of the mesorectal node. So we have created the CTV primary and then the CTV elective volumes. Now we do a CTV final, which includes a combination of CTV primary and then the CTV node and then the elective CTV. And then we create a PTV and give a 5 mm if you're going to do a daily onboard imaging. And if you go for a 10 mm, if you're not going to do a daily online volumetric imaging and just you are going with an offline imaging. So what are the OARs which are need to be contoured? The bowel loops, the bowel cavity. It can be contoured either as loops or the cavity, and bilateral femoral heads, bladder, and the external genitalia. It forms the important OARs in the radiotherapy. And the target volume objectives are make sure at least the 95% of the volume receives 95% of the dose, with the median prescription dose should be 100 plus or minus 2, and the Dmax should be volume receiving 107 should be less than 15% at least. Keep it as low as possible. Next, coming on to the acute toxicities. So we need to explain these toxicities before planning a patient and get their informed consent. And these are so that the patient are aware that these toxicities are expected during treatment and they are mentally prepared to handle this, which will help in improving the patient compliance. So the acute toxicity would include fatigue and then the skin reactions, which can range from dry to moist desquamation, which is usually seen in between the buttocks, especially in the natal cleft region. And hematological toxicity is found especially when concurrent chemo is being administered. So we need to do a weekly review of the blood counts, and cystitis can happen, which can be taken care of by giving plenty of oral fluids and by alkalinizing the urine. And diarrhea, obviously, it's a side effect of small bowel dose, which can be managed with loperamide or codeine, and tenesmus and abdominal discomfort. These are the side effects which are expected during the course of radiotherapy or immediately after completion of radiotherapy. And the lead toxicity would include sterility, that's why it is very important to give the options of fertility preservation in appropriate patients before starting the patient on radiotherapy. In males, we go for a sperm banking. In females, we go for a oocyte or a ovarian tissue or the embryo preservation. And in females, menopause can happen because of radiotherapy, and chronic bowel dysfunction can happen. Anal stenosis and fecal incontinence can happen mainly because of the dose to the sphincters. And telangiectasias of the rectum and bladder can occur, which can lead to bleeding. Any doubts till now? Any questions, Anupam?
Yeah, Kannan, I think you have explained it
hello?
marvelously well.
One question.
Yeah, there are 2 questions actually. Yeah, Abhay, you can please. Ambir, you can go through the questions now.
Yes, there are 2 questions asked. The
Yes.
first question is asked by Dr. Abhay. If the flat pain between bladder and rectum is indistinct on T2 weighted MRI, should we either consider it as bladder invasion or confirm the same by cystoscopy?
So if you have always a doubt, it is better to go for a cystoscopy because that will confirm the bladder infiltration. So, and still if you have an uncertainty, then it is always better to include if you have a doubt. Because if there is obvious frank infiltration, that would be obvious. So if it is just a loss of fat plane or this thing, it is better to go for a cystoscopy.
Okay, sir. I hope it is clear. The second question is asked by an anonymous attendee. I request please put your formal name to ask any question from next session onwards. The question is this: can 3-field be given in supine position also?
Yeah, it can be given, but only thing is you will if you have in supine position, you will have the interference with the couch. So when it is when you're planning for a 3-field, so it's always better to put in a prone position so that you have a direct posterior beam, and then you don't have any interference with the couch. But still, you can plan supine also. There is no problem with that. It is up to the comfortability of the patient and the convenience of the patient. If
Okay.
patient finds difficult to lie prone and not comfortable, then we can still do it supine.
Okay. I think the questions have been very well answered by Dr. Kannan. Kannan, just I have a wee bit query. It's just before we
Yes.
go to anal canal part,
Yes.
Kannan, the thing is that you have very nicely shown how do we contour the GTV and then include the anterior lumen of the rectum as well. But sometimes across conferences and when we visit other physical workshops, students have a query. What if we don't contour the rectum or the GTV per se and straight away contour the mesorectum as a primary CTV? So is it some kind of a practice that we should encourage, or what are the problems that would happen due to this?
No, it is always, suppose if you need to give a boost, then we need to
Yes.
have a volume, right? So people
Yes.
nowadays even plan simultaneous integrated boost to the gross
Yes.
tumor. So in
Right.
such cases, we need to have the target volume delineation for the gross
Absolutely.
tumor.
Absolutely. So this is what I have always told, junior colleagues who have tried to straight away contour the mesorectum, skipping the the primary. So
It
we should
is
always make it a habit to contour the primary, because boosting is very important
it
at the
is
end of it.
always recommended, never skip the standard methods of contouring. Always start
Yes,
with your GTV, go for a CTV. So it may be any site it is. Okay.
exactly.
The protocol
Exactly.
is standard.
Exactly. And before Kannan, you go to the second part, that is the anal canal. I would request Hambir, if
Yes.
there is any question from anyone anonymous, don't read that question, because we are not going to entertain any anonymous attendees. Okay. If at all people want to ask, they have to log in with their real names, and then we should be taking forward those questions.
Okay, sir.
So I guess
Noted.
it's yeah. So I think Dr. Kannan, you can go ahead with your second part of the talk.
Next is the anal canal. So I would be covering this. Then I have some cases. If some people is interested in wanted to see the contouring of some structures, you can tell me. I have the images. I can show you and contour and show you. Okay. So now the coming on to the anatomy of anal canal. The anal canal is just 4 centimeters long. It extends from the anal margin here, and then it goes 4 centimeters above it. And anal margin tumors are the tumors which are located around the skin, around the anal orifice. And the most common location of the anal canal tumors is the transitional zone, which is just above the dentate line. This is the dentate line, and where we have the transitional zone. And the tumors arise most commonly from this side, and they extend proximally into the surface of the rectum. Coming on to the lymphatic drainage of the anal canal, it can be divided into 3. One is you have the anal margin tumors, which usually spreads to these inguinal nodes and then to the external iliac nodes. And then we have tumors proximal to the dentate line, and then we have tumors distal to the dentate line. The tumors proximal to the dentate line, they usually go into this mesorectal, that is the superior rectal, superior hemorrhoidal, internal iliac, obturator, and presacral nodes. Whereas the tumors below the dentate line, they go to these superficial inguinal nodes and the lower mesorectal nodes. So the standard treatment for anal canal tumor, it is chemoradiation. There is no controversy in it. Always go for a radical chemo-RT if patient is fit, which is mitomycin C plus 5-FU plus RT. Even if it is not fit, we go for a low dose mitomycin 5-FU and radiotherapy, because that has produced dramatic responses in anal canal. And when do we go for a surgery? We go for a surgery if there is a history of prior radiotherapy to the pelvis, or patient has a renal transplant, which is there in the pelvis. And these are the only 2 indications we'll go for an upfront APR. In all other non-metastatic cases, radical chemo-RT should be the standard of choice. So what are the pre-radiotherapy requisites we need to have? Again, we need to have a full history and examination findings, and examination findings should include your digital rectal examination findings, noting the size of the tumor, and then the presence of any inguinal lymph nodes. And if it's a female patient, make sure that you have done a pelvic examination to rule out any vaginal infiltration or a vaginal fistula. And then get a biopsy, possible under anesthesia, and then do an MRI pelvis, and for the local staging and the CT thorax and abdomen to rule out visceral metastasis, and then go for a PET CT scan if it is more than T2, and do baseline bloods, including HIV, as anal cancer is an age-defining illness, and discuss about the fertility options in patients, especially in young patients, because there is risk of sterility with your radiotherapy. So, and before taking the patient for radiotherapy, we need to assess these three things. Make sure that patient is not an obstruction, patient doesn't have fecal incontinence, and patient doesn't have fistula. If these three things are there, the defunctioning stoma should be done prior to planning the patient for radiotherapy. Then, as I said earlier, consent is very important after explaining the acute and then the late complications of treatment. And patient setup for anal canal cancer. Again, we have supine position. We go supine with arms on the chest and knees supported by a wedge. And this is stable and it's comfortable. And similarly, prone, as I said earlier, it has a dosimetric benefit, but it is less stable and then comfortable for the patient. Now, another important position which we use in anal canal is the frog leg position. So this we use especially in bulky patients if we have a lot of inguinal folds to allow the sparing of the skin in the upper inner thigh. We go for a frog leg position. And the second indication we go for a frog leg position is whenever we have a large perianal extension where we will not be able to put a bolus in the supine position, approximate the bolus exactly to the tumor in the supine position, we go for a frog leg. Next is bolus. So when do we use the bolus? So we always decide whether to use a bolus for a patient or not, see the MRI and see whether there is any perianal extension is there. If it's a mild perianal extension is there and the tumor is adequately surrounded by the surrounding tissue, that is the buttock, then there is no need for a bolus. You can just go ahead with a supine position and then plan it. But if you have a tissue, or if you don't have a tissue around the tumor, then those are the patients who require definitely a bolus to increase the dose to the tumor. And the second indication where we use bolus is bolus over the groin. We use when if you have an ulcerated inguinal lymph node, or if you have a lymph node with skin fixity because of extracapsular extension. So here I'm showing an example. You can see the two MRI of two patients, and these are the axial slices. Here you can see the lower limit of the tumor. This is the tumor which you can see, and it is adequately surrounded by the tissue all around. So in this case, I wouldn't not use a bolus. Whereas in this, if you see, you can see a tumor perianal extension, and you can see a gap around the tumor, and there is no tissue. So in this case, I would prefer to use a bolus, and then I would simulate the patient in frog leg position. So this is exactly the patient corresponding to this MRI. So here we have used bolus for the perianal extension as well as for the inguinal region with which had bulky lymph nodes. And the bladder protocol remains the same as for rectal cancer. We go for a comfortably full bladder with a 500 ml over 45 minutes to reduce the small bowel dose. And rectum, we ensure that the anteroposterior diameter is less than 4 centimeter. Next, coming on to the radio-opaque marker, keep the marker at the anal verge as well as at the distal point of the disease. And if you have any palpable groin nodes, you can wire it if you're doing a 2D simulation. Then again, contrast, it remains the same. If you want to use it for a 2D simulation, you can use it. And then IV contrast for the CT simulation and oral contrast for the delineation of small bowel lobes. Next, coming on to the data acquisition with CT, which starts from around L2, L3 junction, and inferiorly we go up to 4 centimeter below the lesser trochanter with a slice thickness of 3 mm. And coming on to the target volumes, here it includes the primary tumor, the entire anal canal, and the lymph node regions at risk, which include the bilateral inguinofemoral nodes, external iliac, internal iliac, obturator, and mesorectum, and presacral lymph nodes. So I have dealt about the boundaries of these lymph node stations in rectal cancers. Whichever I have not covered, I'll cover it in this. So before that, I'll finish the 2D planning for anal canal cancers. So if you see the 2D planning, there are n number of techniques to plan for a 2D technique, which has been used traditionally for a large number of years. But there are many techniques which are complicated, but I would always recommend to keep it as simple as possible. So which is the ACT2 or trial protocol which they have used. It's a UK-based trial. So it defines the target volumes in terms of field borders for a two-phase shrinking field technique for the anal canal. So if you see the phase one, so the phase one, if you see the borders for anal canal tumor, superiorly we go. So we see the inferior border of sacroiliac joint, mark it, and then go 2 centimeters above it, and that marks the upper border of the volume. So that would cover your internal iliac and then the external iliac, because as I said, the common iliac divide at the level of the inferior aspect of the sacroiliac joint into the external and then the internal iliacs. So giving a 2 centimeter margin above the inferior aspect of sacroiliac joint would adequately cover your internal and external iliacs in the upper level. Or you go 3 centimeter above the GTV if you have it. And inferiorly, we go again 3 centimeter below the tumor or 3 centimeter below the anal verge, whichever is more inferior. Since it's an anal canal tumor, we see where the tumor is and then go 3 centimeter below it, or you go 3 centimeter below the marker at the anal verge, whichever is more inferior, you mark that as the inferior boundary for the phase one. And lateral, our aim is to include the inguinal lymph nodes. So we go beyond the lateral, beyond the femoral head that is passing through the neck of the femur, which will adequately cover the inguinals. And here you could see the same thing. We go 3 centimeter below the tumor, and this is the sacroiliac joint, inferior border. We go 2 centimeter above it, and laterally we go till the ASAS or the lateral border of the femoral head, passing through the neck of femur, covering the inguinal region. In phase two, I'll discuss the beam arrangements after the boundaries for this phase two. So in phase two, if you see the superior and inferior and lateral, it's very simple. You find where the level of the tumor is and then mark 3 centimeter above, below, medial, all around the tumor. So that would mark the boundaries for phase two. Suppose if you have an inguinal lymph node positivity, then what do you do in phase two? So in phase two, again, it's same. You wherever you find the nodes, just mark it, and then you make sure that you include 3 centimeter of the tumor, 3 centimeter of the volume around the tumor. So that will mark the borders for the phase two volume. So now coming on to the beam arrangement. So phase one, we can go for a simple anterior and posterior opposing beams with a 6 MV to 15 MV photon energy, depending upon the separation of the patient. Especially if it's a bulky patient, go for a higher photon energy like 15 MV, which would give a satisfactory dose distribution. So in phase two, if no lymph nodes are there, then we go for a 3 fields, which includes a single posterior and then 2 laterals, or a single posterior and then 2 posterior obliques, or a 4 beams. And if it is a lymph node positive, then we go for a same anterior posterior opposing beam similar to phase one. So there are so many other techniques like wide AP, narrow PA, or you go for a 3 field followed by anterior electron dose to the inguinal region. So, but this is fairly easy and simple, so to plan and deliver, and patient will complete the treatment without much significant toxicities and without much complexities in planning. And the dose recommended for the phase one is 30.6 gray in 17 daily fractions of 1.8 gray, which is given over 3.5 weeks. And for phase two, we go for a 19.8 gray in 11 fractions at 1.8 gray over 2.5 weeks, so amounting to a total dose of 50.4 gray. Next, coming on to the 3D planning for anal canal. So again, the principles remain the same. Have all your information available. Fuse the diagnostic MRI with the planning CT. Involve your colleagues if you are in uncertainty. So here the target volumes would include, again, same. We contour the primary tumor. We contour the involved nodes. Then we give a margin for it. to account for the microscopic disease for the primary as well as for the nodes. Then we go for the elective volume, which includes the lymph nodes or the regions which are at high risk of having a microscopic disease. So what does it include? So the primary tumor, the GTV primary would include the gross primary tumor, which you can see in the CT scan. You can use the MRI for delineating also. And GTVN will include the gross node. Here you can see the gross inguinal lymph nodes. So make sure you contour all the lymph nodes which are present. And what is the CTVP? The CTVP, it's a margin to account for the microscopic disease. So from the GTV primary tumor, we give a margin of around 1 centimeter around it for the early tumors like T1, T2. Whereas if it is locally advanced, like T3, T4, or if it is a node positive cases, then we go for a 1.5 centimeter margin around the GTV. So once you have created this volume, what do is you see whether the anal canal is included in entirety in the volume. So what is the anal canal? Anal canal, it extends from the anal verge where we have kept the marker, and it extends approximately 4 centimeter above it, and that is the anal canal. So make sure that you include that 4 centimeter of the anal canal in the CTV volume and edit it off from istio-anal fossa or any muscles if it is not infiltrating into it. But make sure that in the lower part, you include both the internal as well as the external sphincters and edit off from the bone and then the muscle. The CTV for the lymph nodes, which include approximately a 5 mm margin around the involved nodes. Make sure that once you give a 5 mm, if a node is there, if the muscle is there, and if it is not involved, then you can edit it off from the muscle. Here you can see this is the pectineus muscle. So next, coming on to the delineation of elective CTV. Elective CTV will include the bilateral inguinofemoral nodes, the external iliac, internal iliac, obturatus, and we generally include lower 5 centimeter of the mesorectum alone if mesorectal
Hello, sir.
nodes are.
Sorry to interrupt you.
Sorry.
No, Kanan, please go on.
So include the lower 5 centimeter of mesorectum if mesorectal nodes are absent. If mesorectal nodes are involved, then we include the entire mesorectum, that is up to the bifurcation of the inferior mesenteric artery or at the S to S3 junction. And next is the presacral lymph nodes. So I have covered most of the stations in the rectal cancer. So I would cover just the external iliac and the inguinal lymph node contouring in this. The superior border of this external iliac forms the superior border of internal iliac, that where you start, that is 2 centimeter above the inferior aspect of sacroiliac joint, and that forms the superior boundary, or you go 2 to 3 centimeter above the upper border of your GTV volume. Either it's a node or a primary. If it is inferior, you go up to the femoral head. That is where you see the femoral head start appearing. You stop the contouring of external iliacs there. And laterally, we go till the iliopsoas muscle. Don't go into the muscle. And medially, we go 7 mm medial to the vessels. And again, if bladder comes into it, please don't edit it because the bladder filling is variable. And anteriorly, you go 7 mm anterior to the external iliac vessels. But if some lymph nodes are there, it's better to go around 1 to 1.5 centimeter anterior, especially towards the lateral side. And posterior boundary will be formed by this internal iliac. This is the internal iliac groups, and that forms the posterior boundary of this external iliac. Next, coming on to the inguinal lymph nodes. So before contouring inguinal lymph nodes, you need to know certain structures, which are the muscles around the inguinal compartment. So one is the sartorius muscle and another one is the iliopsoas muscle. So this is the sartorius and then the iliopsoas, which will form the lateral boundary of the inguinal compartment. And this is the pectineus muscle, which you can see attached to near the pubic region. And that forms the posterior boundary. And below it, we will have this adductor longus, which also forms the posterior boundary of it. So we go posteriorly up to these level, and then laterally we go till the sartorius and then the iliopsoas level, and anteriorly we go at least 5 mm below the skin surface, and then medially we go up to this medial edge of the pectineus muscle or the spermatic cord in males, or if you can see the inguinal fold, you can stop at the inguinal fold. And this forms the boundaries for the inguinal lymph nodes. So here you can see the contourings. This is the inguinal lymph node compartment, which is contoured. And you go inferiorly till the level where you see the lesser trochanter. Now coming on to the PTV. So we generally follow a simultaneous integrated boost technique here. So we create a separate 3 volumes. One is the PTV primary, which will include the CTV primary plus a 10 mm margin, and we go for a 5 mm if daily online imaging is done. And for the PTV node, we give a 5 mm margin from the CTVN, and for the PTV elective, we give 5 mm from the CTV elective. And this is the dose schedule which we use, which is 53.2 gray in 28 fractions to the primary tumor, that is the PTV anal canal, and 50.4 gray in 28 fractions to the PTV nodes, which is the gross node with a 1 centimeter margin, and 40 gray in 28 fractions. We go to the elective volumes, which includes all the lymph node stations at risk. So you can go for a sequential also, in which we go for the same doses used in 2D, that is 39.6 followed by 19.8 gray. So I have come to the end of the lecture now. The take-home messages for the accurate target volume delineation. You need to have knowledge of these 3 things. One is where are the sites of recurrence it could be, so that you include that in your target volumes. Then we need to identify what structures are. So we need to know the clinical anatomy as well as the radiological anatomy, which is very much essential to be successful in target volume delineation. So with this, I complete. These are my references from which I have taken the material, and thank you.
Thank you, sir. Thank you so much. One question has.
Yes.
Kannan?
Yes.
Yeah, I think there are some network issues at Hamid's end. So there is one question that has been given by Dr. Zia again. And the question is there any difference between abdominal versus pelvic presacral lymph nodes contouring?
No, I'm not able to. Between presacral and?
Is there any difference? Is there any difference between abdominal versus pelvic presacral lymph nodal contouring?
No, abdominal means I don't understand.
I think he wanted to ask about the pelvic lymph nodes. I mean,
no, there is no difference as such. Only the difference I would say is the presacral lymph nodes. In all other cases, we would go till only S2 S3 junction, the inferior border. Whereas in rectal and anal cancers, we ensure that the entire presacral space is covered. So we go till the tip of the coccyx, as that is most common site of recurrence. So we contour the entire volume from S1 till coccyx.
Yeah, I think I think you're right in this case. So I think we got some time with us. Kannan, if you don't mind, could you please show in a DICOM viewer like how do we go about the mesorectal contouring or the rectal contouring, if you can give any example, because we still have some good 10-15 minutes time with us.
Yeah, I can share it. So, but so I'll show a rectum case. Can you see my screen?
Yeah, we can see your screen. There is one more question before you go into that. It's like this is Dr. Rajal, and he asks, what is your opinion about elective inguinal irradiation in CA rectum extending into anal canal?
Elective inguinal irradiation in CA rectum extending into an inguinal anal canal.
Yeah.
So in CA rectum, we do not routinely include inguinal region. But if you see the lymphatic drainage, I don't think it is wrong also to include the inguinal canal. Whenever there is rectal tumor which goes into the anal canal, obviously the lymphatic drainage can go to the rectum, the inguinal region. So it is you can contour it, but I personally don't do it. I just contour only the nodes. I don't do it electively unless if they are involved. That's what I do. And there is no consensus on it, and there is no data available on it whether to be included or not. But I don't think it is not wrong to include an inguinal node when there is involvement of the anal canal.
Yeah, exactly. Shantanu Pal sir is there. Sir, Dr. Kannan has come to end of his talk, and we will be just going ahead with some live examples of contouring of CA rectum, sir.
It was a wonderful presentation. At this age also, we have learned quite a lot. Thank you, Dr. Kannan. It was a very illustrative one.
Thank you.
I think it will do very good for the PGTs and the junior and senior residents. Thank you again. Please do come back again and again. Help us.
Yeah.
Thank you so much.
Sir, we'll go ahead, sir, with some examples. You can sign out. We will go ahead with some small little examples of contouring in CA rectum, sir. He is going to show us live, sir.
Anupam, shall I start?
Yeah, please, Kannan, please start.
Okay, so this is a case of a CA rectum. So this is the planning CT scan. So we had simulated with a marker at the anal verge, which you can see. This is the anal verge marker. Then we have found the lower border of the growth on digital rectal examination prior to simulation. And we have kept a marker in that. See,
Kannan,
yeah.
I think your screen is not visible. No, you just
Not-
you unshare this thing. No, I think this
okay,
is
I
the
will stop
rectum.
sharing that and I'll share again.
Yeah.
Okay.
Now this is visible.
Now is it visible? Yeah. Okay, fine. So this is a planning CT scan of a CA rectum case, which is planned for neoadjuvant treatment. So we had simulated from L2 L3 junction to 4 centimeter below the lesser trochanter with a slice thickness of 3 mm. And prior to simulation, we had kept a marker at the anal verge. And then we had done a digital rectal examination and we had kept a marker at the lower border of the growth. So these are the images. So you can see this is the distal border of the growth marker and this is the anal verge marker. So why it is important, now you can understand, because it is very difficult to say in the CT scan where the lower limit of the disease is. Here you can see very well that there is a thickening of the rectal wall. So you can say this is abnormal. So as you go down, you can see the thickening. So, but as you move, even here you find the thickening. So, but as you move down, so if you have not placed a marker, it would be really difficult to identify where exactly the growth ends. So I always prefer to keep a marker because that definitely helps me. And because always the MRI fusion may not be perfect because you don't do it in a planning position, radiotherapy treatment planning position. But if MRI is available, please do fuse the MRI with the CT scan, which will be really helpful. So as I said, the target volume delineation would start with contouring the GTV. So I can show you that. So you can see this, always start from the slice where you can see the obvious growth, where there is no uncertainty at all. So you can see, so we can contour the entire lumen along with the tumor. And then, so this is how the GTV is contoured. So I always prefer to include the entire lumen rather than the tumor alone. So this is the lower border of the growth where I have kept the marker. So I go till that level. So this forms the lower limit of the growth. Here you can very well see this is the levator ani and this is the muscle. So even I will go up to this level and then I'll include it. So this forms the GTV, and superiorly you go till where you can see the growth and then you contour till that level, and that forms the GTV primary. Then always, whenever you have done the planning CT scan, always look for the lymph nodes from above. Start from the aorta and then the vena cava. Look around the vessel, see if you could find any significant lymph nodes on either side and search for nodes. And if you could find any, please contour the nodes. So I think in these cases, there are no significant nodes I could find apart from small inguinal lymph nodes, which could be inflammatory. So if there are no gross involved nodes, then the next step would be to go for a CTV primary. CTV primary, we give, as I said, a 10 mm margin from this tumor. I think color is not. So which you can give around the tumor, which is 10 mm around the tumor, can give. And suppose if you are if it is an upper tumor, then it is better to give a 1.5 centimeter margin anteriorly. So that will form the CTV primary. So next, coming on to the elective lymph node volumes. So elective lymph node volumes, you always start at S1 S2 junction or 2 centimeter above the upper border of the growth. So the S1 S2 junction can be easily identified by looking at the sagittal view. So this is the sagittal view of the patient. See here, you can see the markers. This is the anal verge marker, and this is the distal border of the growth marker. And this you can see the thickening. It's really a long segment growth. So see, if you take S1, S2, so this is the S1 and this is S2 and this is L5. So if you see that, here if you take S1 S2 junction will not will cut through the growth. You will not have any margin above it, so it is always go 2 centimeter above the growth, and then you mark the upper boundary of that. So always use the sagittal view and then decide about the upper boundary of the volume. So since this is a fairly long segment, so it is very easy to go with just S1 S2 junction alone for a tumor which is located in the mid rectal, because you have a lot of normal volume above it. So in this case, definitely I would not keep at S1, S2 junction, and I would go at least 2 centimeter above the upper border of the growth. So if you mark, this is the upper border of the growth, I could see the thickening here. So if you say this is the upper border, then we go at least 7 slices above it, which will mark the upper boundary. So once you have seen the 7 slices, you start contouring the lymph node levels, the upper border of the elective lymph node from those levels. So these are the lymph node levels. So you just contour 7 mm around the vessels. And make sure you don't include the muscle and then the bone. And we contour the external iliac only if there is a nodal involvement or if there is anterior organ involvement. So if definitely a pelvic node, an internal iliac node is positive, or an obturator lymph node is positive, then definitely we do include the external iliac lymph node station in the elective volume. So this is how you contour. Then the presacral volume, as you said, this is the S1. You start from there, and then it is contoured using a 10 mm brush. Sorry, here in this viewer, I don't have a brush, so it should be like this. So if you see the entire volume, it should, so you ideally you go till, sorry. So you go till, sorry, it's not working. So if you just contour as a separate structure, you go till the sacroiliac joint, which you can see. If you contour presacral as a separate structure, then this will be the volume. So, but if you contour as a single elective lymph node volume, then you can contour. I can show it. If you contour as a single volume, you can go directly like this and do it. Go till the sacroiliac joint and don't go into the vessels. And another thing is, you make sure here you can see that there is a sacral notch with the nerve root. So in such sites, you make sure that you include that sacral notch. That is very, very important. So this is how the volume looks as we go. So another thing I want to say is here the bifurcation of the inferior mesenteric artery. I think here you can see the two vessels. So this probably forms the superior rectal and then the sigmoidal vessels, which will correspond approximately to around S2, S3 junction, which will mark the upper boundary of the mesorectum. So the lymph node volumes, as we go down, we include the external iliac, internal iliac, and then the presacral. So from here in this CT, you can very well nicely see the mesorectal fascia. Generally, in a CT scan, it's not very easily visible. So, but in this case, you can see the mesorectal fascia very clearly. So the mesorectal lymph nodes are contoured. along the mesorectal fascia, but anteriorly you go 1 centimeter anterior to the organ, whichever is present. Then posteriorly you go till the sacrum. So the S2 S3 junction will mark the upper border. So this will be the upper border of the mesorectal nodes. Here you can see the vessels. Probably these could be the superior mesenteric, the superior rectal, and then the sigmoid vessel. So what do we do is we generally go. So the volume, if you are going internally, including external iliac, we contour like this, and then we go. And here you make sure that you are at least 7 mm anterior to it, or 1 centimeter presacral volume is there, whichever is more anterior, we have to go take that. And that's how we go. So this marks the upper boundary of the mesorectum. And then lower down we go, you can see the mesorectal fat. This is the mesorectal fat. You can see the mesorectal fat, and then it starts disappears from this level. So which exactly corresponds to our growth. So we should not stop our mesorectal volume here. We should go at least 2 centimeters below it. So that will mark the boundary of the mesorectum. You can very well see it in coronal if you want. Coronal, I will show you. This is the coronal view. So here you can see. So this is the rectum, and this is the growth which you can see, and this is the levator ani muscle. And this is the insertion of the levator ani muscle, and this forms the sphincter. So generally this, and you can see that we have kept the marker here at the distal border of the growth, which is exactly corresponding to the level of insertion of the levator ani. So in this case, the lower boundary of this mesorectal volume will go at least 2 centimeters below it. So we have to go at least, if you see, this is the lower border, we have to go 1, 2, 3, 4, 5, 6, 7, at least 7 slices below it, because it's a 3 mm thickness slice. And then we make sure that we contour and include the volume, and it should be including the sphincters. That is very, very important. So this is how we contour the electro lymph node volumes. Then we boolean all thing, and then we give a margin of 1 centimeter, which will be your final PTV volume, and we prescribe the dose to that volume. Is there any doubts?
Are there any doubts? I think you could not have explained it in a better way, like the way you have done it, because we have had classes till now, and we didn't have the live contouring demo as you have shown, Dr. Kannan. And I guess the students who have attended, I guess they will get a lot of benefit out of this particular session. The best part was that in many classes, they don't tell us that you need to include the sacral notch nerve roots. So those part is very, very important. These are small little intricate details that we have always looked into during our residency. So this is very, very important. So if you feel like you need to include or not, there are various schools of thought, but it's better you include the sacral notch nerve roots. And it's very important, like you identify the mesorectum and go 1 centimeter into the bladder wall, because you never know, you can never ensure a proper bladder filling during treatment. So we have a question for Dr. Debanjan Kundu, and he says that, sir, is there any significant effect of variable bladder filling on inner rectal contouring? Should we consider any additional margin for that? I think Debanjan, Dr. Kannan has already told it clearly. Kannan, would you like to take this question once again?
Yeah, I would definitely include it, because I would not edit it from the bladder. Because as I said earlier, the bladder filling is really variable. Even though if you follow a bladder protocol, it varies with patient to patient, and it varies with the season, especially in Chandigarh. If you see the winter season, maybe follow a different bladder protocol, and in summer season we follow a different bladder protocol. Okay. So it varies so much, and there is you can see that daily variation is there definitely. So I wouldn't edit a elective volume which is going into the bladder. Maybe at least other structures like a muscle or a bone, definitely I would do it. So, but not in the bladder.
Right. So, so I guess there are no further questions. So thanks a lot, Kannan. I think we have finished well in time. You have stuck to the norms that you were given, and you have exceeded our expectations in this. So we look forward to your to association with you with our future academic programs. and it will be our pleasure to have you once again, all over again, Dr. Kannan. So with this,
Certainly.
yeah. So with this, I would like to conclude the today's module. And next, just a housekeeping announcement. Next Wednesday is 30th of November. Since the AROI is starting from 1st of December, we are not having any class next week, next Wednesday. The next class will be on hepatobiliary malignancies on 6th of December. And following Wednesday on 13th of December, we will be going to the upper GI malignancies. So we go from lower GI to hepatobiliary to upper GI malignancies, and then we will finish up this module of GI malignancies. We request all of you to be present during those classes. And if you're having any participation in the form of poster or oral papers or quiz competition in the Central AROI, we on behalf of AROI West Bengal chapter wish you all the very, very best. We look forward to your company on the 6th of December. Thank you so very much. Have a very pleasant night ahead. Good night. And Dr. Kannan, thank you so very much once again.
Thank you, Dr. Anupam, for the opportunity.
Thank you so much.
Yeah, bye.
That's it.